All right, thank you very much. My name is Matt. It's nice to meet you all. I like to say that I have a love-hate relationship with infection preventionists. You guys, I really appreciate the fact that I'm safe and my patients are safer, and I'm not getting C. diff today because of you guys. But you also ruined the 5 second rule for me. Like every time I drop a piece of candy on the floor and I'm like, I'm gonna eat that. And now I'm like, no. And it started at the hospital, like instantly. There was no 5 second rule at the hospital. And the more time I spent around people like Rachel and Yama, the more that moved over to my life. So now there's no 5 second rule anywhere. And that makes my life a little sadder, but also healthier. So I appreciate you all for that. So that's my love-hate relationship with you guys. Um, I'm a substance use support service assistant manager for Norton Healthcare. This is a fairly kind of in the scheme of healthcare, a relatively new program. We've been around. I built this program about 6 years ago at Norton Healthcare. Prior to being at Norton Healthcare, I worked in substance use treatment and medication for opioid use disorder treatment, and then also helped for 4 or 5 years start the syringe exchange for the city of Louisville and guided that program along. We take a pretty unique, I like to think, approach to working with folks, and you will kind of see more of that as we talk. Our objectives for the day, they're there, we have to have them, and we're moving on. All right, so what we're going to do first is we're just going to spend some time looking over just kind of the core tenets of a harm reduction approach to working with folks who use drugs, kind of give you guys some understanding about the thinking or the theoretical approach that guides kind of how we work with patients and what our interactions, what guides our interactions, and the way that we talk with folks. And so we'll look at 8 core tenets, and then we'll kind of look a little bit about how they might apply to you. So the first one is just that people use drugs. We accept for better or worse that licit and illicit substance use is a part of our world and chooses to work to minimize harmful health effects rather than simply ignore or condemn them. So at the end of the day, people they're going to use drugs. People have been using drugs and drinking for a long time. I think probably there was at one point in life somebody saw like an animal maybe eat some rotten fruit under a tree and stumble around and thought that might be a good idea, or eat some mushrooms or something and acted funny, and somebody's like we should give that a shot. And ever since then, people have been using mind altering chemicals. That is a reality of our world. I think when we think about the hospital space right now, we are seeing more substance use, not less of it. I looked at just our downtown hospital on any given day. My caseload is probably, 5 to 7% of our overall kind of inpatient bed population. Not looking at moms and babies, but looking at our adult population, that they're about 5 to 8%, which is a pretty significant chunk of our hospital population. And so when we think about our people, the reality is people use drugs, people drink. It's a part of our world, and we can kind of keep what we've done doing for a long time, which is kind of shame people or make them feel bad about their substance use, tell them they need to not do it. Where we can take maybe a different approach where we realize that it is a part of our world, that it is happening, and there may be more helpful conversations we can have about how to minimize harmful effects of individual substance use versus just saying, hey, you need to stop doing that. Uh, Complete side note, there was a lot of flooding and there were some high water signs on the road. And I sent a picture of the high water sign to my team, and I thought it's getting bad out here. Even the water is using drugs. And I really wanted to like laminate like a just say no to drugs thing and stick it on the high water sign. I thought that'd be really funny. I didn't do that. But it just made me think about the reality of like we have had like if you grew up in like when I did, if you're maybe in your 40s, of like the DARE campaign and just say no to drugs, a woefully ineffective approach to working for prevention. But we, from a hospital standpoint, and just even from like a medicine standpoint, we tend to be really paternalistic in care, and so we kind of present ourselves as experts in people's lives, and we say, hey, you need to stop doing this and start doing this. And for folks that are in the hospital, it typically isn't the most effective strategy, namely because most of our patients who are in the hospital I like to say like 10% of our patients are here because they're pregnant, they get hit by a bus, something crazy like that, or they're just old and they're dying, and a hospitalization is a part of that process. So that's like 10% maybe of our patient population. The other 90% are here with us because they either met with a doctor and the doctor said, hey, you should start doing this or stop doing this, and they didn't do that. Or someone looked at them and said, hey, you really should go see a doctor, and they decided that they weren't going to go see a doctor. So we already have most of our folks are already people who, for lack of better terms, have struggled with medical compliance and following through with recommendations. And so rolling up in somebody's room and saying you should stop doing this, it just tends to not be an effective strategy. Number two, success is a moving target. We establish a quality of individual and community life and well-being, not necessarily the cessation of all drug use. as their criteria for successful interventions and policies. I learned really early on in the work that we do that if the only success was someone stopped using substances long term, I was not going to experience success a lot with my patients. I think for most of us, when we think about the process of making behavioral change, we do not look at the kind of the end stage goal for behavioral change and go, hey, when I reach this point of I've done everything that I needed to do and wanted to do and become the person that I want to be, that then I'll consider my work success. When we tend to look at change within ourselves, we kind of recognize incremental milestones. We recognize sometimes small shifts in our behavior that leads to positive outcomes for ourselves or for others. And so when we think about success being a moving target, we certainly not using drugs, not using alcohol long term is a success point that we're going to celebrate. But we're also going to look across the board at any positive change that improves the quality of life, health, well-being for an individual, the community. That's success. That's a success. Things are better than they were the day before, and so we're gonna work with folks from that perspective. Nothing forced without us ensures that people who use drugs and those with a history of drug use routinely have a real voice in the creation of programs and policies designed to serve them. Real quick, so when I say drugs, I mean drugs. Alcohol is a drug. I just want to lump that in there. I'm sorry if that offends some people. If you drink alcohol, you use drugs. Alcohol is a psychoactive chemical. It affects your body and your brain. And so when I say drugs, just hear alcohol in that as well. It's important that people, not even just important, it's vital, it's essential that people who we are designing programs to serve have a voice in the programs that we create for them. I think some of the greatest waste from the government that we've seen in my lifetime has been because the government said that they were going to design this program to help folks and they didn't ask the people that they were going to help if that was the help they needed or wanted. And money gets wasted that way. When I think about medical interventions, community interventions, things that we do, a lot of times we make decisions for people instead of making decisions with people. And that tends to not suit well or really serve well the people that we're attempting to serve. And so it's important that the people who we're serving they have a real voice in their care, right? So they have, and not just a seat at the table, but they are the table. Like they are the ones that are guiding at the end of the day what they want in their care, what's important to them. One of the rules that I kind of laid out when I came to Norton Healthcare was, regardless of how far I advance within the system, I will always see patients. I'm always going to see patients because I know when I stop seeing patients, I stop listening to folks directly. And I've learned that kind of secondhand, third-hand information is never as accurate or as helpful as firsthand. And so when I listen to something that somebody else, I would listen to one of my staff tell me about an interaction that they had with a patient, I'm getting my staff's perspective on what they thought the patient said was important, right? But not necessarily what the patient views as important. And so I think it's important that when we're designing programs, we're designing interventions, we're thinking about working with people, that we realize that we're working with people. And if we're working with people, that they need to have a real meaningful voice in the programs and policies that we're designed to serve them. Life is complicated. We're going to recognize that the realities of poverty, class, racism, social isolation, past trauma, sex-based discrimination, and other social inequalities affect both people's vulnerability to, capacity for effectively dealing with drug-related harm. I think those are two, vulnerability to and capacity for are really important. It's interesting to me when we talk about drug use and we think about drugs, most people are going to go, drugs are bad. I would argue that drugs are not bad. Drugs are fantastic. If you break your leg, you're going to be really glad that there's drugs. Y'all use drugs or support the use of drugs all the time because antibiotics are drugs, right? So drugs used in the right way at the right time in the right place can be really, really helpful. Drugs used in the wrong place at the wrong time can be really, really harmful, right? And so when we think about drugs and we think about drugs kind of being bad, if drugs truly were bad, if drugs were really the problem that our folks had, we would expect that, and when I say the problem, I mean the main source of the problem that our folks had, we would expect that people kind of across the spectrum who are using that drug would have the same outcomes, right? Maybe would there be some variability that we could adjust for, but for the most part, we would expect that folks who say drink 6 beers a day, if beer really is the problem, folks that drink 6 beers a day, we would see the same kind of outcomes across a wide socioeconomic diverse group, right? If cocaine was really the problem, if heroin was really the problem, if methamphetamine was really the problem, if that drug was really the core issue, and that drug in itself was bad, and the reason that the consequences were experienced, we would expect, once again, across that spectrum of people, that we would see a relatively similar outcome of consequences. And we don't. We know that people who have money, people who are part of kind of the dominant class in society. We know that people that live in neighborhoods that are not frequently policed. We know that people who have access to health insurance and healthy food and who have stable employment, we know that those folks have wildly different outcomes across the board than our folks who are less privileged, who live in neighborhoods that are heavily policed or belong to people groups that are more likely to engage with the police. We know that folks that have less access to medical care, less access to adequate nutrition, health insurance across the board, people that are live in neighborhoods that are unsafe, where there's higher rates of domestic violence, you name it. We know that those people, they tend to have far more consequences associated with their substance use than their counterparts on the other end of that spectrum, which suggests that really more so than drugs being what is causing or being the main source of problem in people's lives, and that really be the consequence is, the reality is that what is going on in people's lives and the context of what their lives look like has more to do with how vulnerable they are to substance use, and then in addition to that, how vulnerable or their capacity for dealing with that harm. We're not a monolith. We understand that drug use is a complex, multifaceted phenomenon that encompasses a continuum of behaviors from severe use to total abstinence, and acknowledges that some ways of using drugs are clearly safer than others. So not everybody who uses drugs are the same. Like I both greatly appreciate when I went to a 12-step meeting and I was told I was not unique. It let me know that I wasn't alone. I wasn't the only person who was dealing with some of the things that I was dealing with. I also, now at this stage of the game, find it a little less than helpful in some spaces, because I know that I am unique. I know that I'm not like everybody else. I know that my life experiences aren't the same as everybody else's life experiences, and how I use drugs and alcohol isn't the same as how everybody else uses drugs and alcohol. There are differences between me and other people. I'm no better, no worse, but I am different, right? And maybe that I need different interventions or supports than other folks do. And so it's important that we realize that when we talk to folks, that we're talking to a person, that is an individual, and that there is a continuum of behaviors around substance use, and that there are folks that do really use drugs pretty sparingly, even though they still use drugs. There are people that just use cocaine on occasion. Just because someone has a cocaine positive drug screen doesn't mean they use it every day. And that drug use really encompasses from really severe use, daily use, heavy use, to total abstinence. And this idea that there are, I think from IP folks appreciate this, there are safer ways to use drugs than other ways. Injecting drugs is a whole lot more risky than orally taking a drug or smoking a drug, right? There's higher risk for infections and things like that, increased risk for overdose as well. And so we're going to acknowledge that there's a continuum around drug use and that people themselves are individuals. Judgment free, we call for the non-judgmental, non-coercive provision of services and resources to people who use drugs and the communities in which they live in order to assist them in reducing attendant harm. So when we work with folks, we're non-judgmental. I tell people all the time they're adults, and as adults, they have the right to decide what they put in their body. And as another adult, I don't have the right to have an opinion about that. We're also non-coercive. So we're not going to withhold care or withhold something that's appropriate or helpful for a patient if they don't do what we want them to do. And so it used to be where we said, well, we're not going to give you Hep C treatment if you don't stop using drugs. That's coercive, right? We don't do that anymore, thank goodness. We still do the hospital. Some had a patient the other day who wasn't doing what people wanted them to do. And so they said, well, we're not going to give them their pain medication. And I said, we need to hold on for a second. We give people pain medication because they're in pain, not because they did their labs. And so if that person's in pain, they need to get their pain medication. So it's really important that when we provide care, it's judgment-free, it's non-judgmental, it's not coercive, and we'll really meet people where they are in order to reduce the harm that they associate or experience because of their drug use. Empowerment, we affirm that people who use drugs themselves are the primary agents of reducing the harms of their drug use, and seeks to empower people who use drugs to share information and support each other in strategies which meets their actual conditions of use. I like to remember that I might be a subject matter expert, but I'm not a subject matter expert on you or anybody else that I meet, right? I learned that in a very personal way this week with some issues we have with our kids. I thought I really knew one of my kids, and I found out that one of my kids is struggling with some things I had no idea they were struggling with. I'm an expert on me. I'm not an expert on you, and I'm not an expert on your life. And so when we think about that, it's important when we walk alongside people, we realize that I'm not here to make change in someone's life. I'm not here to drag them, push them along. What really I'm here to do is empower them. I'm here to support them. I'm here to give them information that they may or may not have, and help them process that information, support the choices they make to improve their health and their well-being. and do that in mind with the understanding that the people that I work with have a better understanding of what their actual conditions of their drug use looks like than I do. I have maybe a picture that they've shared with me, but they have a better understanding of what their day-to-day life is, and that puts them in a much better position to move forward with making change. And then the last thing is the idea of information, not opinions. We're not going to minimize or ignore the real and tragic harms and danger that can be associated with illicit drug use. So I'm going to give people I'm going to have really honest conversations with folks. I don't have a problem with looking at people and say, hey, if you continue to inject drugs, you do increase the risk of your endocarditis. Like, so you got endocarditis, you just got a valve replacement, you inject drugs, you're at a much higher risk of that valve getting reinfected. And I think the wording of that's important because I said if you inject drugs, if you smoke drugs, if you ingest drugs orally, you're not at a higher risk for a valve infection or getting that valve infected in the same way that you are if you inject drugs, right? And so I think it's important that we're giving people information, that we're having honest conversations about risks associated with choices, both positive and negative outcomes that people can face. Um, but we're not telling people what to do. Our role in people's care is to inform them about how their decisions are affecting their health and then allow them to make choices based on what they value and what they feel like is important to them. So when we think about it from like an IP standpoint in the hospital, one of the things that stands out probably the most is the need for us to adequately treat the signs and symptoms of withdrawal. And I say that, because IPs a lot of times you guys are in patients' charts and you're also in their rooms, right? And so you're seeing patients, and if you've met somebody and they're in opiate withdrawal or stimulant withdrawal, it is pretty clear that they're not feeling well, right? Um, and so even if you're reviewing a chart and you're looking at medications and you realize, hey, this person, they have a history of injection drug use and it doesn't look like they have any medications for withdrawal, or you're in a person's room and you see issues, you got a chance to speak up and say something and really help guide somebody's care. So when I think about signs and symptoms of treating withdrawal, the importance of that, it improves patient outcomes. People are more likely to participate in their care. And if people are more likely to participate in their care, they're more likely to have a better outcome. They're also likely to not be in our hospital for as long. So when people have their signs and symptoms of withdrawal treated and they're engaged in care, we see a reduction in length of stay, and reduction of length of stay leads to a reduction of hospital-acquired infections or risk for that. Antimicrobial stewardship. The last thing we want somebody to do is start on an antibiotic for 2 days and then walk out of the hospital and not come back for a month. We know that the more that we stop and start antibiotics, the more issues there are. Also with other medication, antibacterial medications, that whether we're treating a fungus, a bacteria, you name it, those can shift and grow and develop resistance. And the less that people follow through with those medication regimens, the more issues that we see. And so helping somebody be comfortable enough that they can stay in the hospital, making sure that their withdrawal and their pain is treated so they're actually able to sit in the bed and complete their care is important. It reduces the risk of substance use in the hospital. The hospital is like the sketchiest place to use drugs for two reasons. The one would be is there really is an illusion of safety. I'm in a hospital, if something happens, I'll be okay. But the reality is if you're in the hospital and you're not on a tele unit, you're someone's checking in with you once an hour, right? A nurse once an hour, and then a PCA is going to come in the other hour, and they're going to flip flop. And so it's very possible that if you decide to use something and you don't know the potency of what you're using and you have an overdose, it's really possible that someone's not going to come check in on you for another 55 minutes. And by that time, you're probably going to be dead. Or if not dead, there could be other like life-altering, from hypoxia, that life-altering things that could happen to you. And so there's this idea that my patients have that if I use drugs in the hospital, it'll be safe. But the reality is you might actually be safer at home using drugs because someone is maybe going to be more likely to check in on you. Also, like there are just bugs. There are creepy crawlies here in the hospital that are not anywhere else. We have our own special blend of stuff that you don't want in your bloodstream. And so there are infections I can get in the hospital that I'm not going to get from injecting drugs even in the alleyway, right? And so use in the hospital is significantly there's significant risk, even more so than outside of the hospital. It improves staff safety. Staff safety. So people that are dope sick, they're not very friendly. I don't know if you've ever been like had the flu and just been awful sick. I'm not the best version of myself. When we don't treat alcohol withdrawal, people can have delirium. They can be confused. They can be agitated. It's a really great way to get hit. If someone's injecting in the rooms, there could be uncapped syringes. There's just a lot of risk that comes in for our staff when folks are using drugs in the hospital, or just if they're agitated because they are in withdrawal. It reduces patient-directed discharge. That's a maybe a more patient-centered way to say leaving AMA. All right, but people are more likely to stay in the hospital in complete care if they don't feel terrible, right? And so we see a lot of people leave the hospital because they're in withdrawal, or they leave the hospital because their pain's not being adequately managed. And what we do know is that when we treat pain, when we treat withdrawal, people are more likely to stay and get care. Reduces their risk for fatal overdose. Obviously, if someone's been in our hospital for a few days and we're giving them some pain medication and they leave, they leave against medical advice, they're kind of in that impulsive state. Um, they're more likely to use a substance that's going to hit them a little bit harder than it would have 3 days ago. And I remind people, a weekend in jail is enough to drop your tolerance, enough to increase your risk for overdose, and so is a weekend in the hospital. So just because you were taking some pain medication, it doesn't mean that when you leave here, if you use that you're not at risk for overdose because of decreased tolerance. And so if someone's leaving against medical advice, they're kind of already in that impulsive state of mind. There's just a higher risk for that impulsivity to continue with how they use drugs and just increase the risk for overdose. And then last but not least, we're just going to decrease our risk for readmission. So people can complete care because we kept them comfortable and they're able to engage in what that next step down level of care is. They're less likely to need to come back to our hospital. So those are all important things for treating the signs and symptoms of withdrawal. I think as people in the IP space, and really all of us who are in the hospital that are having direct engagement with patients or in patients' charts and kind of have an idea what's going on with patient care, um, we can be advocates for presenting patients with all the options. And so I think it's really important that we don't tell people what we think they should do. Um, I think it's important that we present people with the options. People will sometimes ask me, well, Matt, what do you think I should do? And sometimes if I know them really well and we've had a lot of conversation, I'll say, hey, based on the things that you told me, um, this is what I think would be a good fit for you. Other times, if I don't know somebody really well and they say, well, what do you think I should do? I'll go, I don't really know you well enough to answer that question. And if people ask me, Matt, what would you do? I'll say that's the wrong question because what I would do might not be what you should do or you need to do because we may not have the same values. What's important to me may not be important to you and vice versa. And so I think it's really important that we present people with all the options that are available, even the ones that maybe we don't like as much. Informing patients of all the benefits and risks. And so, hey, here are all of this option. Here are all the positive things you could experience because of it. Here are some of the risks associated with going this route. And so looking at all the options, but also informing once we give people the options, hey, these are the benefits and the risks of those options. And then acknowledging patients' rights to choose. And so we present people with information and then they make a choice. We need to acknowledge that our patients have the right to choose. They have agency and they have the right to use it. They have the right to make decisions. Just because someone makes a choice doesn't mean we have to go along with it. And so if someone says, I want you to do this surgery or give me this medication, well, that doesn't mean that it's going to happen if we don't believe it's appropriate from a medical standpoint. But in general, more often than not, what I see is we give people information and patients just choose an option that we don't like, right? So they're not going to go to treatment or they don't want to take their antibiotics or whatever it might be. They don't want to do their labs. They're going to continue using substances. They're going to continue drinking, whatever it might be. And we tend to have opinions and share our opinions with our patients, or sometimes we just allow it to color what our follow-up relationship, how we continue to engage with those folks. And so I think it's important that we're advocating for those things, that people have options. They have all the information they need to make an informed decision. And then we acknowledge that people have the right to make choices. And we're going to support the choices that people make for their own lives. We may not like them. We may not even agree with them, but we are going to support people's rights to choose. Thinking about it from a practical infection prevention standpoint, I think it's really important that from infection preventionists, infectious disease doctors, that we're advocating that people who use drugs get treated with HIV for HIV and Hep C. We know that when we treat folks for HIV and Hep C, we know that it significantly decreases the risk of the spread of HIV and Hep C, and we also know that even folks who aren't fully compliant, especially with hepatitis C meds, we know that even when they're not fully compliant, we still can treat hepatitis C, even with some medications. We see, sometimes 50, 60, 65% compliance is enough to actually knock it out. And so we also know that when we educate people about safer use, and we connect them with the materials they need for safer use. So we teach people about safer injecting, not sharing supplies, and we give them supplies that they need to inject. We know that they're less likely to spread HIV, Hep C, or also get reinfected. We know that people who access syringe services are much less likely to see a recurrence of their Hep C or their HIV. I'm sorry, a recurrence of their Hep C once it's been treated. I think it's important we increase access to PrEP. I would love to see the long-acting injectable PrEP be available to folks in this space. I think we see a lot of patients who we can test for HIV. We can have conversations there in our hospital long enough that we can do the tests we need to do. We can have conversations about when was their last potential exposure, and if they fall with outside of the window of that infection, they had enough time. I think now it's like 7 to 10 days, depending on the test that we do. But if someone says, "Man, I haven't had a potential exposure, haven't shared a syringe, haven't had unprotected high-risk sex for 7 to 10 days," that's enough time for us to get them started on PrEP. You give somebody a shot, and that's 2 months of coverage, right? That's 2 months where someone has much less risk of acquiring HIV. And so I think that's really important that we're increasing access to PrEP, and we're doing it in a way that meets the conditions of people's lives. So some people are going to be fine on that oral medication. Let's give them the oral medication. Other people, they're gonna do better in the hospital if we give them a shot, and at least they're covered for 2 months. And honestly, for some of our folks, as much as we see them, we could probably keep them covered for most of the year if we use that in the hospital. I think it's important we educate on safer use and sex strategies so that we're just giving people the education they need to reduce the risk for infections, and then support the distribution of safer use and sex supplies. And so we're going to make sure that after we give people the information they need about how to be as safe as possible, we give them the materials that they need to be safe. So that was a 60-minute presentation in 26 minutes and 38 seconds. So with that said, if you have questions today, I'd be happy to answer any questions you have. I also want to encourage you, if you have questions about what we do, how we do it, or ways that you might be able to shift practice where you work to better serve the needs of folks who use drugs or alcohol, certainly feel free to reach out, give me a holler. Happy to be supportive to you and the work you do in any way that I can.
Thank you very much. Does anybody have any questions for Matt? I do think that this is a great program that we have. Pretty staggering, the percent that you said of people that need your services. So obviously we have some opportunities. So we've got some comments in here that this was great. So thank you very, very much. And like Matt said, I think that you all saw his contact information. So if you have any questions or want to reach out to him at a later time, please feel free. And thank you all very much. We'll have our next grand rounds in 2 weeks. Thank you, Matt.
You're welcome. Y'all take care.